right, good morning, everyone. All right, so before I start, I just want to, can we tone down the light a little bit? So please raise your hand if you work in the Cath lab. I don't see anything, yeah, all right. Anybody who admitted, anybody working in cardiology and admitted STEMI patients? Have you ever admitted STEMI patients? How about discharged STEMI patients? All right. Okay, so obviously this topic is for everyone, but especially for all those who raised their hands. So please pay attention, okay? All right, where is the next? Oh, how do you put the next forward? Okay. So before we start, I want you to watch this slide.
Did she say mom?
Hurry!
Oh! Okay. I don't know what happened. We were fooling around and then he just said he felt funny and then he just collapsed.
Hey, what is it?
I'm okay, fine.
Does your chest hurt?
Sit up.
Call 911. Tell them to send an ambulance. Mare, now! Oh my God. What are you doing? Mouth to mouth.
I have to cut the slide. You cannot hear the next word. I'm good. But I think this is very important because all of us work in the hospital, and this is actually the story before they even arrive to the hospital. This is what we miss sometimes. So when we have the EKG paper in front of us, it's not just a piece of paper. It's not just numbers, letters. This is the first step. But as clinicians, when you work in the cath lab, when you're a nurse, you're a tech, you're actually thinking, what is the artery involved? What wire will I prepare? What guide catheter should I prepare? Should I pull the balloon pump? What is this case about? This is going to be a train wreck. So if you look at this, if you look at 2-3 AVF, you're anticipating it's an RCA. And just for everyone here, 1 AVL lateral in the 5 and 6, and the V leads are anterior septal. So with STEMI cases, sometimes we get so excited, we get so nervous. It's a combination of both. And all I can say is nothing beats the adrenaline rush when you have a STEMI patient coming. And I think most of you can attest to this. So with Jack, our patient, we don't know if it's an inferior wall STEMI, and on the right side, you can see a juicy RCA. Submit, don't get too excited. It's hanging by a thread. Is it anterior wall MI? You can look at the V leads. You can see that subtotal LAD, or it's a lateral wall MI. And look at that, 1 in AVL, and you see that there's no circumflex, 100%. So these are the different scenarios that we're confronted with whenever you have a STEMI patient coming. And you know that time is, we all know time is muscle, so we all have to move fast. We have to know what to do. Everybody has a role and everybody has a responsibility, and we have to do it very fast because we don't want the muscle to die. We don't want this patient ejection fraction to be lower down and then go to heart failure. So this leads to my main topic, Mission Lifeline. What is Mission Lifeline? Maybe most of you are not familiar with this term. So Mission Lifeline, actually, American Heart Association recognized the gaps and issues in STEMI treatment around 2003. There were volunteers and leaders. During that time, they said there are some gaps in our treatment. So they started collecting data, and in May 2008, Mission Lifeline was launched. This was primarily a STEMI system of care improvement process and recognition initiative. There are more than 600 hospitals who give their data, provide their data for this quality improvement program. So Mission Lifeline merged with ACC Action Registry to become Action Registry Get with the Guidelines. So they have all this gold mine of data, they review, and they use proven guidelines and best practices to treat patients suffering from acute coronary syndrome, including STEMI and non-STEMI. So the main goal is to help save lives, improve patient outcomes from symptom onset all the way through cardiac rehabilitation. This is now beyond door to balloon, because whenever we hear STEMI, for the longest time, you always think, oh, it's door to balloon, we're doing good. So we are now recognizing some from the video clip, from the time the patient had symptoms until we discharge the patient. So I want to focus on our hospital, Mount Sinai Hospital, and I want to share our story. So the background is, we know that since May 2008, Mission Lifelines existing, and we've been submitting data. But it's only through Q1 2017 that Beth, our vice president, she was the one who spearheaded and asked me, Heidi, we need to focus more beyond the door-to-balloon data. We have to evaluate our metrics, and we have to get better. So there was a huge motivation for focus on process change and process improvement. We evaluated Mount Sinai Hospital door-to-balloon data, which was outstanding. It's always been outstanding. But the other STEMI pathways and metrics, not that outstanding. So we have a work to do at that time. The difference with Mission Lifeline is it's multidisciplinary. It's exciting, it's very challenging. We have to communicate and collaborate with EMS, the paramedics. I have to start making phone calls with FDNY, the firefighters. So you have this debates, argument, but they worked with us and starting phone calls with the transfer services, referring hospitals, even the involvement of the security of the referring hospital who has to watch the bay to make sure that the ambulance has a parking space. So that was the start 18 months ago. So this slide is very important. This is really the Mission Lifeline. So you can see that there are 3 different pathways where you receive your patient. It could be a walk-in in ED, and this pathway means it's up to the time we reperfuse the vessel. So tied up to this ED walk-in is a door-to-first EKG. Did you know that the EKG must be done within 10 minutes when the patient has chest pain and STEMI? So this is tied up to the door-to-balloon, which you're very familiar with, so it has to be within 90 minutes. The second pathway is from the field. Like Jack, our patient, the first medical contact. So the metric starts when the ambulance arrives and the paramedic starts doing the EKG. It also has to be done, we have to open the vessel within 90 minutes. So you have all these challenges. How far is that? Is the patient living on the 15th floor? Is the elevator working? I remember an incident that I have to question the paramedic. I said, why it took you 40 minutes to bring the patient? It's just a mile away. And then he said, you have to remember it's on the 15th floor, Heidi. We have to use the stairs. So these are very interesting conversations I had for the past year. And another challenging pathway is transfer patients. So we are, our sister hospital is Mount Sinai Queens. So everything has to be seamless. Imagine that less than 120 minutes we have to open the vessel from the moment the patient walks into the emergency department. So another tied up metric is the door in, door out. So imagine that STEMI patient walking into Mount Sinai Queens within 30 minutes, the patient has to be getting out of that ED department. So the transfer services is fully involved also with this process. So this is the Mission Lifeline, the AHA, that we're really providing our data with, and we're very focused in improving our process, so we try to really meet the metrics provided. So these are 3 slides, will be very busy, but I just want to show to you the different pathways that different leadership we created, we evaluated, and we approved that will be all accountable on hours, off hours, and these different pathways. This is it's like our Bible here. We follow with every STEMI case. The first one was the ED walk-in. This is what we're going to do. It's all algorithm. Second is from the field. And then the last one is transfers. So it's busy slide. I don't want you to damage your eyesight here. So 18 months ago, we started STEMI process and structure. What did we need to do at that time? Of course, we have to review the contact information. We cannot move forward if all the phone numbers are wrong. So we have to review all the STEMI pagers, the phone numbers of on-call attending, the fellows. We reach out to the fellows. So, and even all the staff, we just validated all the phone numbers. Then we started using the pre-notification from EMS. The EKG at that time, that was like, why are we not transmitting the EKG from the field so that we can have early activation? So it was also started at that time. It can go what technology can do, what Samit was saying. Once they do an EKG from the field, it transmits to the on-call attending phone so they can evaluate if it's really a STEMI. We developed the Mount Sinai Hospital, Mount Sinai Queens STEMI Pathways and benchmark for on-off hours, which you just saw the 3 slides. So the ED, leadership in ED, Cath lab, transfer services, and the referring hospital, we all were accountable in following all these pathways. We have expedited EKG for walk-ins, and we have the dedicated EKG machine. So 18 months ago, Mount Sinai Queens, they have 1 EKG. I said, no, this will not work. We have to have additional EKG machine, and here in our hospital, there has to be some specific EKG machine for chest pain patients. So that happened. The staff on call, they also stay in-house, most of them. They don't want to go home. They just keep staying here in the hospital. So when the pager gets activated, they're in the cath lab in like 2 minutes. So we have the STEMI Epic order set in the ED. Everything's standardized. Whoever is working, fellow resident, you order the same things. And before we started the process, also when we order the medications, the PCA will go to the pharmacy, pick up the medications here and in Queens, said it's not going to work. So we created a STEMI med pack. It's in the peak season, both EDs. So when the patient's real STEMI, you grab that pack and give the medications to the patients. We have improved communication between ED and cath lab. We have the RN handoff form. We validated the times. And then we also have the standardized AMI core measure section in EPIC. And what is this about? This is the ADS, the cardiac NPs in the hospital. They're fully involved here. We made sure we sat down with the St. Luke's leadership also. We collaborated just to make sure that before we discharge the patients, if this is a true STEMI, did we give ACE inhibitor, beta blocker? Did we do smoking counseling? Is this patient referred for cardiac rehab? So these are all the metrics and every standard that every provider must check off. And lastly, education is very important, that everybody must be educated and trained so that we all are in the same page. We also had the QI and feedback process. So what we did 18 months ago, we started reviewing the STEMI case immediately. Within 24 hours, cath lab and ED leadership, we review the case and we get the feedback from the staff and the quality team, what worked, what didn't work. And there's also a monthly feedback process involving the EMS and the FDNY. And with STEMI transfers, within 2 days, we have a phone call with the transfer services, and with Jennifer also helping me, the manager of the cath lab. We have all this data, and we review over the phone. And we have monthly meetings, and what do we discuss? We have a STEMI dashboard, all the summary discuss. We go over every case and just evaluate what really helped us, what is working, and what are the areas for improvement. So I just want to share with you, the director of Mission Lifeline forwarded this couple of slides, the next 3 slides. For 2017, she sent this to me last month. So the requirement is for all the cases, at least 75% of the cases should meet the metrics. This is from the first medical contact to device, and Mount Sinai had 79% of the cases meet the metrics. And this one you can see here, it's clear that on the right side, the time is really faster compared to 2016. But what is significant here is the ED time. From 36 minutes, the patient staying in the ED in 2016, it went down to 26 minutes. What does it mean? The ED staff, they're fully involved. Every staff, they know what to do, the text. So they have the dedicated EKG machine. The patient comes in, you do the EKG. Once the EKG is done, you give to the physician to interpret, and then the physician activates right away. And then while they're waiting for the fellow to come to pick up the patient's already, the gown is, the clothes is changed to gown. We hook the patient on portable oxygen, the portable defibrillator, the portable cardiac monitor is already hooked up. So everything's ready when the fellow comes down. So the time was cut down by 10 minutes within 1 year. And for STEMI transfers, we know that the goal is less than 120 minutes, and you can see that our data for the past year was less than 120 minutes. So a lot of effort, teamwork, and this is just to piggyback Beth's presentation, the first presentation, that it really will not work if it's not total team effort and collaboration. So because of this, if everything became successful. So what really is important is focus on quality and excellence. We all were on the same page, said we really want to be better. We started educating everyone. So teamwork and collaboration from different disciplines happened. In staff and team engagement, we empowered the staff. We heard their voices. We get feedback. And they are the ones, they're actually the voices of the nurses and the techs are very important because they are the ones, you're out there, you have the first-hand experience. So they always tell us like what really is working and not. And we make everybody accountable. Feedback process also is very important because that's how you also validate your work. And we have to be consistent. We always say, Dr. Sharma always says this, you cannot be great by being good one time. You have to be good all the time. That's how you achieve greatness. So it's very important to have consistency. So because of this, I just want to show you our awards this year. So we received the Silver Award. It means that 4 consecutive quarters that you met the metrics. This is from Mission Lifeline, AHA. The AHA that merged and the ACC, 2008, they're now separated. So the Action Registry now That's why you can see at the bottom part, we got the Platinum Award from the ACC Action Registry and Silver Award from Mission Lifeline. And we really want to go for the gold. We want to continue succeeding with meeting the metrics this year. And I think this is, again, I will emphasize that this is not possible without the Cath Lab staff. And this is the great Cath Lab STEMI team. I just want to please give them a round of applause. This is not possible without them. All right. All right. Thank you very much for your time.